Endoscopic Management of Lynch Syndrome and of Familial Risk of Colorectal Cancer, European Society of Gastrointestinal Endoscopy, ESGE Guideline. Introduction. Colorectal cancer, CRC, is the fourth most incident cancer and the second leading cause of cancer-related deaths in Europe. While the majority of CRC is sporadic, twin studies have shown that up to 35% of CRC cases have a familial component. In 2% to 5% of CRC cases, a genetic origin has been identified. The most common hereditary CRC syndrome is caused by a constitutional pathogenic variant in one of the DNA mismatch repair (MMR) genes, MLH1, MSH2, MSH6, PMS2, or the 3' end of the EpCAM gene. It is also known as Lynch syndrome, LS, and was previously termed hereditary non-polyposis colorectal cancer, HNPCC. Among CRC cases, about 2% to 4% are caused by LS. As well as increased CRC risk, individuals with LS have a higher risk of developing endometrial, gastric, small bowel, biliary tract, ovary, urinary tract, brain, and skin cancers. Because of the high cancer risk, it is of great importance that clinicians recognize individuals with LS in order to make appropriate management decisions for both the patients and their at-risk family members. CRC cases associated with polyposis syndromes are discussed in a separate guideline. However, for most cases of CRC with a familial component, no genetic origin is found. The CRC risk in this heterogeneous group of individuals varies. The actual CRC risk depends on the number of family members affected and the age at diagnosis of any affected family member, and surveillance should be offered to these individuals based on their estimated CRC risk. This guideline provides an overview of the endoscopic management of individuals with LS. Furthermore, the authors aimed to define familial risk of CRC for those individuals at high risk for CRC, to whom, therefore, surveillance should be offered. Since endoscopic management strategies for LS and familial risk of CRC vary widely, the authors aimed to gain consensus among European experts by using a Delphi process. Methods. The ESGE commissioned this guideline, Guideline Committee Chair JVH, and appointed a Guideline Leader, MVL, who invited the listed authors to participate in the project development. The key questions were prepared by the coordinating team, MVL and VR, and then approved by the other group members. The coordinating team established task force subgroups, each with its own leader, and divided the key topics among those task forces. The process of developing the guideline included telephone conferences, meetings, and online and face-to-face discussions among the members from July 2018 until July 2019. Searches were performed in Medline, Embase, and the Cochrane Library. Articles were selected through title and abstract screening, followed by full-text screening. The results of the search were presented to all group members, and consensus statements were created. Evidence levels and recommendation strengths were assessed using the Grading of Recommendations Assessment, Development, and Evaluation (GRADE) system. Further details on the methodology of ESGE guidelines have been reported elsewhere. Since literature on familial colorectal cancer and LS is limited, a Delphi process, usually consisting of 2 rounds, was used in order to obtain consensus. All members, except for the research fellows, were asked to complete the online Delphi questionnaire in isolation, and responses were anonymized to prevent participants from influencing one another. In each round, members were asked to rate all the statements with their level of agreement using a 7-point Likert scale. If the statement was not within their area of expertise, participants could opt out. Secondly, participants were asked whether the statement was clear and had the opportunity to make suggestions for improvement. After the Delphi round, all statements were discussed and adjusted, if necessary, during a face-to-face meeting. Consensus was reached when 80% or more of the group members had voted either very strongly agree, or agree during the second Delphi round. Third and fourth Delphi rounds were organized only for the statements regarding advanced imaging. In July 2019, a draft prepared by MVL and VR was sent to all group members. After the agreement of all group members had been obtained, the manuscript was reviewed by a member of the ESGE Governing Board and an external reviewer, and was sent for further comments to the ESGE national societies and individual members. After this, it was submitted to Endoscopy for publication. This guideline was issued in 2019 and will be considered for update in 2024. Conclusions. ESGE recommends that individuals with Lynch syndrome should be followed in dedicated units that practice monitoring of compliance and endoscopic performance measures. Strong recommendation, low quality evidence, level of agreement 100%. ESGE recommends starting colonoscopy surveillance at the age of 25 years for MLH1 and MSH2 mutation carriers and at the age of 35 years for MSH6 and PMS2 mutation carriers. Strong recommendation, moderate quality evidence, level of agreement 100%. ESGE recommends the routine use of high-definition endoscopy systems in individuals with Lynch syndrome. Strong recommendation, high-quality evidence, level of agreement 100%. ESGE suggests the use of chromoendoscopy may be of benefit in individuals with Lynch syndrome undergoing colonoscopy. However, routine use must be balanced against costs, training, and practical considerations. Weak recommendation, moderate quality evidence, level of agreement 89%. ESGE recommends definition of familial risk of colorectal cancer as the presence of at least 2 first-degree relatives with colorectal cancer or at least 1 first-degree relative with colorectal cancer before the age of 50 years. Strong recommendation, moderate quality evidence, level of agreement 92%. ESGE recommends colonoscopy surveillance in first-degree relatives of colorectal cancer patients in families that fulfill the definition of familial risk of colorectal cancer. Strong recommendation, moderate quality evidence, level of agreement 100%.